Okay, so I would like to introduce Angela. She is going to give us a candidate talk. She's an applicant for a tenure track position within the epidemiology department for a behavioral health, social epidemiologist, or mental health epidemiologist. So Angela has a PhD in public mental health from Johns Hopkins. She did two postdocs, one at NICHD and then a second at NIDA. And she's currently a prevention scientist within the Population Mental Health and Wellbeing program at the School of Public Health. So maybe we can hold our questions to the end, and please welcome Angela.
Thank you, Tessa. Good morning, and thank you for coming. Today, I'm going to talk about addressing trauma and resilience to improve adolescent perinatal mental health. Here are my goals for today's talk. So I'll talk a little bit about me and my work as a psychiatric epidemiologist and prevention scientist, and end the talk with how I would like to grow as faculty in the Department of Epidemiology at Colorado School of Public Health. What makes individuals thrive and flourish even when they face huge life challenges? And how can we help people reach their potential? Questions like these led me to study psychology as an undergrad at University of Washington. I initially wanted to be a therapist, so I did my master's in clinical psychology at Teachers College, Columbia University. Interestingly, this is also where I learned about public health and its effort to prevent mental disorders. And I thought, that's it. That's what I want to do, prevention. Then I found out there is a School of Public Health that has a department dedicated to mental health. So I earned my PhD in public mental health from Johns Hopkins Bloomberg School of Public Health. My dissertation study was on assessing sociodemographic and psychological factors of binge eating, which is the most common eating disorder and a form of problematic impulsive behavior. I did my first postdoctoral training in the health behavior branch at NICHD. And I went back to Hopkins for my second postdoctoral training as my research interests evolved to include substance use prevention and perinatal mental health. Then I came here to Colorado School of Public Health and have been working with Dr. Jen Leiferman and for the Population Mental Health and Wellbeing program since July of 2018. I am trained as a psychiatric epidemiologist, and I focus on prevention science. And my main research interests include assessing common factors of youth risky behaviors, including substance use, particularly marijuana use and related disorders, and using mindfulness as a prevention strategy that fosters self-regulation. The terms like psychiatric epidemiology and prevention science are relatively new to public health. Psychiatric epidemiologists study the occurrence and distribution of mental disorders at a population level and identify key factors of mental disorders in efforts to inform and develop effective strategies to treat and prevent mental disorders and to promote population mental health. As a prevention scientist, I visit all three domains of prevention science. For epidemiology, I assess prevalence of mental disorders and its key factors. For intervention, I study ways to reduce negative outcomes and increase positive outcomes. And for research methodology, I use tools not only to design studies and conduct analyses, but also to carefully and meaningfully connect with communities. We can understand health issues within a multi-level framework, ranging from molecular events to broad structures of a society. A person's mental health and many common mental disorders are shaped by various social, economic, and physical environments operating at different stages of life. We can take actions throughout life course to provide opportunities for both improving population mental health and for reducing risk of mental disorders that are associated with social inequities. And as mental health is linked to physical health, improving population mental health would also improve overall population health. My research focuses on individual risk factors and working with communities. The first project I will present consists of quantitative epidemiological studies called Psychosocial Factors of Marijuana Use in the General U.S. Adolescent Population. The project was supported by a NIDA training grant and resulted in 2 publications. Adolescent marijuana use is a public health concern due to its high prevalence. The latest report shows that almost 36% of youth in Colorado and nationwide alike reported to ever have used marijuana, 6 to 7% before the age of 13, and nearly 20% reported current use. Marijuana use has harmful consequences, especially for those who start using it early, such as decreased executive functioning and social-emotional areas of brain development, and increased engagement in other risky behaviors. And although youth marijuana use hasn't gone up in Colorado since the legalization of adult recreational marijuana use, continued prevention and intervention efforts are important and needed. One way to inform such effort is to study its psychosocial factors at an individual level, such as personality and coping. Each personality and coping has been suggested as a key risk factor for substance use. Personality is often defined as a tendency of an individual's cognitive, emotional, and behavioral responses. A recent meta-analysis showed personality, particularly disinhibition-related traits such as low conscientiousness and agreeableness, which correspond to high impulsivity and aggression respectively, as risk factors for adult substance use. Neuroticism is a risk factor for several mental disorders, but mostly with internalizing mood disorders. And findings regarding the associations between neuroticism and substance use are mixed. The trajectories of these maladaptive personality traits are modifiable by early intervention that teaches self-regulation skills, such as coping. Often defined as a cognitive and behavioral response that individuals use to manage perceived stress, coping is an important factor of one's present and future well-being. Coping is also considered personality in action, meaning individuals with a certain personality trait are more likely to engage in a certain coping style. Evidence suggests that each coping and personality have shown independent and interactive effects on health. And although no certain coping style is inherently good or bad, disengagement coping styles have been identified as risk factors for substance use when compared to engagement coping styles, which are considered adaptive coping styles. Past studies that have looked at these associations were either small-scale studies with clinical or community samples that consisted mostly of adults, or studies that looked at substance use by grouping alcohol, tobacco, and other drug use together, but not specifically on marijuana. Though we aim to assess association of each personality and coping and its association with marijuana use using a nationally representative sample of adolescents in the United States. By doing so, we intended to provide more rigorous evidence regarding these associations, which in turn would guide intervention efforts. Though we hypothesize that adolescent marijuana use will be positively associated with maladaptive personality traits, namely impulsivity, aggression, and neuroticism, and positively associated with avoidance and distraction coping as maladaptive coping styles, but negatively associated with problem solving as an adaptive coping style. We use data from the National Comorbidity Survey, Adolescent Supplement, and CSA. Our study excluded 13-year-olds due to their low prevalence of marijuana use. Our outcome variables were lifetime marijuana use, grouped as ever versus never, and also past 12-month frequency of marijuana use, grouped as daily or near daily, moderate, and infrequent. Personality and coping were our predictor variables. For personality, participants rated on a 4-point scale how true the statement was for them. For instance, I often do things without thinking of the consequences for the impulsivity scale. For coping, how much they would engage in, for instance, daydream about how things used to be when handling stress for the avoidance scale. We applied complex survey weights prior to all our analyses, and we calculated prevalence and relative risk ratios, adjusting for age, gender, race, ethnicity, and parent education level, with the significance level set at p-value less than 0.05. Now our study sample, older adolescents and adolescents with lower parent education level, reported higher lifetime marijuana use. And more boys and those in the other race ethnicity group reported higher frequency of past 12-month marijuana use. As hypothesized, for personality, impulsivity, and aggression were each associated with higher lifetime use and higher frequency of use. This is consistent with findings from previous studies with non-nationally representative samples of adolescents and adults. Neuroticism was only associated with higher lifetime use. And you can also see that neuroticism showed less robust associations with marijuana use than impulsivity or aggression. That's similar to findings from a recent meta-analysis of adult substance use. For coping, avoidance was associated with higher lifetime use and higher frequency of use. Problem solving was associated with lower lifetime use and lower frequency of use. And this is consistent with prior research on coping with stress, psychological distress, and substance use. Lastly, distraction was associated only with higher lifetime use. Current findings on distraction coping are mixed. Some suggest it's adaptive, and some suggest it's maladaptive. In our case, it seemed it was maladaptive. Although we couldn't test this in our study, but context or sequences of coping could matter. Perhaps using distraction coping as a temporary strategy until you are able to do some problem solving could be adaptive versus using it as an indefinite escape from your reality, which in that case could be maladaptive. Our findings may guide services and intervention efforts. For most children, schools are their primary mental health service providers. But we currently have only a few school-based marijuana use prevention programs that incorporate healthy coping. In several countries, school-based substance use interventions that are based on personality and coping research are being successfully implemented. For instance, the Preventer program screens high-risk individuals based on their personality scales and targets specific pathways to substance misuse, including marijuana. Similar intervention efforts that includes a brief personality screening with the focus on fostering adaptive coping in the United States would help us better understand a child's weaknesses and strengths and tailor to their needs accordingly in order to prevent marijuana use. We can also test a program in the future that aims to target maladaptive factors we just discussed. Emerging evidence suggests mindfulness as an effective stress management tool. Mindfulness fosters self-regulation by practicing to pay attention to your present moment non-judgmentally and to act thoughtfully instead of impulsively. My interest in mindfulness as a prevention strategy led me to my second project called A Qualitative Evaluation of a Whole School Mindfulness Intervention at 2 Baltimore City public schools. 2 foundations that support positive youth development in Baltimore, Maryland, and a NIDA training grant funded this project. And my co-authors and I are working on our manuscript submission. Almost 65% of students in Baltimore City public school system are from low-income families, and over 80% of students are African Americans. Here's an excerpt that shows how trauma disproportionately affect Baltimore City youth. A survey on how our children experience death, and the number of deaths that they experienced were alarming. I likened it to having post-traumatic stress disorder, as soldiers do. However, our children are not post because they are not removed from the situation. Such prolonged exposure to trauma, violence, and stress can have detrimental effects on children's social and emotional development and also academic achievement. So how can we help them? Children who are exposed to constant stress and trauma are also hypersensitive about their surroundings and hyper-alert. We had students who refused to close their eyes in the classroom because they were genuinely afraid something bad was going to happen to them. We also often tell kids to just relax or pay attention, but students often come back and say, "But I don't know what that means," or "I don't know how." Mindfulness can fill this gap. Mindfulness programs have been showing promising results among both adults and youth with increased resilience and self-regulation and decreased stress and symptoms of mental disorders, including depression, anxiety, trauma, and substance use. Lovely gentlemen, Ali, Atman, and Andy, are founders of Holistic Life Foundation. They developed the Mindful Moment program, and it's been my pleasure working with them. Their work has received positive media coverage. Their mission is to help youth in Baltimore and beyond by providing mindfulness and yoga training. The program has 5 core components. Every morning, they played a meditation recording using a PA system. We had student ambassadors who volunteered to promote the program to students. The cool down room was where students could visit whenever they felt uneasy. They could have a cup of tea there, and do their work until they were ready to go back to their class. We also had the Holistic Life Foundation staff at school to guide students and help teachers in difficult situations. And students had weekly yoga sessions. We expected that the program would lead to students' improvement in awareness, self-regulation, and calmness, which in turn resulted in increased academic achievement and positive behavior. The program also intended to be a whole school program, so teachers and staff members also received mindfulness training, which then led to reduced teacher stress and burnout and improved overall school climate. The research team at Johns Hopkins has established a great partnership with Holistic Life Foundation and also the Baltimore City Public School System. So we conducted a qualitative evaluation of the mindful moment at 2 Baltimore City public schools. One was elementary school and another was high school. We interviewed students, teachers, and principals and asked them about what worked for them, what didn't work, and how we can improve the program. And we audio recorded the interviews, transcribed them, and did a thematic coding. Most teachers found the program positive and helpful in reducing stress and increasing calmness, and also in improved ability to deal with difficult students and/or situations. Many teachers also mentioned how the program helped them personally. Here's a quote from a teacher we interviewed. "It reminded me to focus on me, and that's what I started doing. I had actually lost close to 80 pounds. Since then, I fell in love and in a relationship. Then I quit smoking. Mindfulness helped me there." Most students also found the program helpful in calming down and keeping it that way, having a clearer mind and a less negative mind, being able to regulate their emotions and behavior and deal with anger better, and able to focus better. "52% of students also expressed that the program was helpful for their friends." Here's a quote from a student we interviewed. "This girl, she used to be in the halls throwing stuff down. Then one of the mindful moment teachers took her and just told her to breathe every time she gets mad. Now she's in class doing her work right all the time." Teachers also voiced their opinions on program challenges, including having more Holistic Life Foundation staff at school, being more consistent with the clear program structure, working on buy-ins from both students and teachers, and also having more recordings to play in the morning because we had one recording and it was getting really monotonous. Teachers also suggested how we can improve the program. And most of these suggestions correspond to the program challenges they mentioned. High school teachers in particular highlighted the importance of increasing female staff because adolescent girls can connect better with adult females at this stage than adult males. And we greatly appreciated feedback like this because teachers do know best. They know their students, what works for them, and what doesn't. Overall, the Mindful Moment program had a positive impact on children both in elementary and high school, as well as adults in their professional and personal life, highlighting the program's applicability and versatility. In our evaluation, we really wanted to engage with our participants and receive their feedback in person by conducting a qualitative study. In the future, we would like to add some quantitative assessment, particularly the mediating mechanisms of the program, including self-regulation and stress management. It would also be beneficial to gauge overall school atmosphere, perceived social support, and connectedness. We're considering adding classroom behavior observation so we could capture the program effect better. So far, I talked about my work that I have done as a postdoctoral fellow at Hopkins. I will now talk about my ongoing projects that are groundwork for my future research. I learned 2 lessons from the work that I just presented to you. 1, we need to address mothers' mental health to improve youth mental health. 2, we need to address trauma and resilience to improve mental health of vulnerable populations. So I'm currently working on 3 projects on perinatal mental health and 1 on trauma and resilience. I am working with the team at Hopkins on the project called Mindfulness Intervention in a Neonatal Intensive Care Unit Setting, funded by NCCIH. As you can imagine, mothers whose babies are in the NICU are under a tremendous amount of stress, not knowing what will happen to their babies while managing their own postnatal condition. So we created a mindfulness program that suits the particular needs of these mothers, addressing self-care and teaching breathing techniques to be used both in the NICU and during their transition home. We also created a health education program for the control group, focusing on babies' health and how to take care of them. We created audio and video messages for both programs, so moms can either watch and listen to them on the iPads that have it in the NICU or download them on their phones. We are now just wrapping up phase 1, and we interviewed mothers in both mindfulness and health education groups. We're beginning to see that the mindfulness program had a positive impact on mothers, including calming effects and improved connections with their babies and partners, even among those mothers who told us they were not that really into meditation. Versus the health education program, which participants found informative, but had no effect on their mood or stress levels. We're launching phase 2 next month, which will be a pilot randomized controlled trial. My second ongoing project is called SHIP, Survey of Health During Interconception Period. The majority of research and intervention work on postpartum mood disorders has focused on the immediate first year postpartum, and we don't know much about how women are doing beyond that. To fill this gap, Dr. Leiferman collected pilot data to assess mental health and well-being status of women between their pregnancies. We found that 23% of women in our study had high depressive symptoms, and 19% showed high anxiety symptoms, while their resilience score significantly declined as the years since birth increased. We are working on a manuscript based on our findings, and we'll be presenting our work at the International Association for Women's Mental Health Conference next year. We're also working on an R21 submission to NICHD to launch a nationwide survey to gather bigger data and learn more about women's mental health and well-being, as well as their unique needs during their interconception period. In our SHIP study, less than 25% of women reported that they discussed depressed mood with their healthcare providers during the interconception period. Which leads to the third project I'm working on. Funded by AHRQ, we're testing the effects of an online training on prenatal mental health screening and patient-provider communication for healthcare providers in Colorado and Virginia. We are enrolling participants to take a pre-test survey, asking their knowledge, confidence, and attitudes in screening and treating prenatal mood disorders. And they are being randomized into either the online training group, who's going to receive the training module, or the waitlisted group. We're also working on manuscript submission based on the pilot study prior to our current study, which was a smaller scale study on providers only in Colorado. Last but not least, my fourth project is on development of a community-wide ACEs training program. ACEs stand for Adverse Childhood Experiences. The ACEs assessment includes household dysfunction, abuse, and neglect during one's childhood. The original ACEs study was done by Kaiser and CDC among adults, and it showed the significant harmful health consequences of ACEs. ACEs are also carried across generations as described here, highlighting the importance of early intervention, including raising awareness of ACEs. Rocky Mountain Prevention Research Center has a wonderful working partnership with the San Luis Valley community. And the Community Advisory Board in San Luis Valley voiced their concern regarding ACEs in their community. So I'm working with both Rocky Mountain Prevention Research Center and Rocky Mountain Public Health Training Center to develop and disseminate a strength-based program in a format of digital storytelling that'll showcase resilience, caring, and compassion to prevent ACEs. I'm working on getting direct quotes from community members to show how ACEs actually manifest in their community and what community members can do to help prevent ACEs. I presented a progress report at our last Community Advisory Board meeting in November, and it was received well. So I'll continue to meet and interview community members and stakeholders and develop a prototype soon. In addition to developing the program, I'm taking a lead on a manuscript looking at ACEs and resilience in the general US population using the NCSA dataset. And I'll be presenting the preliminary findings at the International Association for Women's Mental Health conference next year. I will end the talk now with summary, some closing thoughts, and ways forward. I showed you this slide in the beginning of my talk to show you what psychiatric epidemiologists do and the domains of prevention science. My first project on adolescent marijuana use highlights epidemiology and quantitative methodology of prevention science. My second project on a mindfulness program evaluation highlights intervention efforts, qualitative methodology, and also community buy-in and engagement of prevention science. My ongoing projects on perinatal and community mental health highlight all three domains of prevention science. The SHIP project focuses on epidemiology. The Mindfulnes NICU and the AHRQ online training projects focus on the intervention. The ACEs study focuses on the intervention and community engagement. And as you can see, each domain doesn't work in isolation. Now I wanted to show you, using my work as an example, how all three domains of prevention science work together and rely on each other. My work I presented to you today is on this conceptual framework. The ACEs project is reflected here as vulnerability and resilience factors and stressful life events. The marijuana use project is reflected here as psychological impairments. The mindfulness project is reflected here as intervention. And it also represents the question that led me to pursue my career as a prevention scientist. What makes individuals thrive and flourish even when they face huge life challenges? And how can we help them reach their potential? Moving forward, I want to combine my knowledge in adolescent mental health, perinatal mental health, and mindfulness interventions to develop and test a trauma-sensitive mindfulness program for adolescent mothers. Trauma history is often associated with perinatal mental health, especially among low-income adolescent mothers. And although adolescent mothers are at a greater risk for developing mental disorders, evidence to guide intervention and treatment is scarce. I look forward to refining and enriching a mindfulness program for this specific population and their unique needs by addressing trauma and resilience, highlighting peer support because of its importance in adolescence and motherhood with the Healt approach. To accomplish this big picture of mine, my immediate steps as a new faculty member would be developing close community partnerships in the Denver area and beyond in Colorado. I recently learned that we have schools in Denver and Aurora for adolescent mothers. I plan to reach out to them and see if we can create synergy by working together. I would also like to collaborate with maternal child health experts to conduct a needs assessment of urban Denver adolescent mothers. I would also love to make connections with the School of Medicine and Children's Hospital, as they have programs for adolescent mothers and perinatal mental health. I would really like to learn from Healt experts and work with the center like the National Mental Health Innovation Center to find an innovative way to improve adolescent perinatal mental health. I plan to seek funding from foundations that focus on adolescent health or perinatal mental health in Colorado, and also small and exploratory NIH grants. And I'm also considering submitting an application for a NIH K01 award. I am truly excited to be here. For the last 6 months I have been working here, I have witnessed the collaborative atmosphere, the energy, and the school's effort to bridge public health practice and research. And happy 10th anniversary! I attended the anniversary event and was so glad to hear mental health was mentioned as a public health concern that we must address. The environment here will nurture me to be a productive prevention scientist. My training in psychiatric epidemiology and prevention science could be applied to existing programs in the department, such as maternal child health and chronic disease. I would also love to mentor and work with students who are interested in making the connections between physical and mental health. I'm happy to announce that I'll be co-teaching a course, The Foundations of Population Mental Health and Well-Being, with Dr. Leiferman, beginning next month. Mental well-being doesn't mean just the lack of mental disorders. And the class will focus on positive ways to boost population mental health, and I'm excited to teach it. And also in the future, I would like to seek funding to develop substance use epidemiology and psychiatric epidemiology classes. My various interests and activities are pulled together through these 3 pillars. As a scholar and a teacher, I would like to be productive in research, teaching, and service, which go hand in hand with advocating for mental health of vulnerable populations, and engaging with communities and working together to empower them to make sustainable, positive change that'll benefit the society as a whole. And I would like to make my academic vision come true here at Colorado School of Public Health. I would like to end the talk by acknowledging my collaborators and supporters, all my co-authors and my mentors and partners at Johns Hopkins and in Baltimore, Maryland. Thank you, Jen, for giving me opportunities to be a part of the Population Mental Health and Wellbeing program. Special thanks to partners at Colorado School of Public Health and in San Luis Valley. I would also like to thank Chloe, Ashley, and Carol. Carol and Ashley were my first contacts in Colorado when I first moved here in April. And Chloe helped me settle in when I started my position in July. And thank you so much for your help and guidance. And a big thank you to numerous agencies that funded the projects that I presented to you today. Thank you.
That was a really great talk. I really enjoyed hearing about the different aspects of your work, and you mentioned that you do quantitative epidemiological research as well as qualitative assessments. I'm curious if you thought about merging those 2 types of data together and how that might give you better insights into some of your research questions.
Yes, definitely. A mixed method, I believe, is the future. Yeah. Because I think quantitative and qualitative in isolation, they could miss a whole lot. Of course, the big data quantitative studies will have statistical power and gather solid evidence and evidence that we could see the associations that we were looking for. But my work, including qualitative, it could take longer, it could be tedious sometimes, but actually we're in public health trying to, work for people's mental health and physical health, and actually connecting with individuals and communities and engaging with them, also talking with them, and then a lot of the times they know better than researchers what's actually going on. So yes, I would love to do both with a mixed method approach to study ongoing and forthcoming studies.
I have one other really quick question.
Yeah.
As someone who's really interested in life course epidemiology, I'm curious if you think there's a critical time frame during which some of your research might be most important.
So my research primarily focused on adolescents, and I usually, when I give other talks, I draw this life course upstream and downstream, and then also the multi-level framework that I just showed you with my talk. And there's a boom on adolescence, puberty. Okay. Yeah. Yes. But as I also studied adolescents and adolescent mental health, and then also this goes back to the Baltimore public school studies with mindfulness, is that a lot of students came back and said, I taught my mom and grandma how to relax today. Mm-hmm. And I was trying to make this connection that it's not just you. It's not one thing. It's one thing to actually address adolescents' mental health, but also their family, especially the mothers, and boosting their mental health could have a wholesome, bigger impact for boosting their mental health as well. I would say motherhood and adolescence will be the two key boom critical periods. Yeah. Yeah.
I stepped out right
Sure.
in a key moment, so I'm sorry if you covered this, but I'm curious if you mentioned how you're measuring resilience in your ACEs program.
So the ACEs program itself, we are conducting series of interviews, and we are basically doing a thematic coding by the interviews, saying what is coming out as active ingredients of resilience in San Luis Valley community. So we first, one theme that really came out during the last interview was that these are our children, and we have to take care of them. So there is that community cohesiveness, and also what came out is they know that they're resilient, they know that they can do it, and the willingness to prevent ACEs in their community. So social connectedness, I guess, would be one label for that kind of theme that we saw. Yeah. Yeah.
I believe it was in your analysis of the factors associated with adolescent marijuana use.
Mm-hmm.
You found a significant relationship for just the other race and ethnic group.
Mm-hmm.
I was curious what was included in that.
So it was just other, which was my frustration as well. And it was, first of all, it was cross-sectional, even though it has a huge sample size. And also, they didn't include Americans, Asian Americans, or mixed, nothing. It just was considered other. And yeah, that was the one limitation that I really wanted to look at, and then I just was not able to. Yeah.
Because sometimes how we group our race and ethnicity categories for analysis can result in a very different other group.
Yeah.
Sometimes there's not large enough sample size of Asian or Pacific Islanders, and so they get put into the other group. Sometimes all Hispanic are separated out into a Hispanic group. And sometimes other becomes mixed races. So it can be this really, not a terribly descriptive group. And when you find significance with that group, you always wonder, is it a spurious finding? So, did all the Asian Pacific Islanders go into that group, or was it people that just identified themselves as other?
I believe the NCSA data gatherer or at Harvard, I think they just labeled it if it was not Hispanic, non-Hispanic whites, non-Hispanic blacks, and everybody else was just categorized as others. And I think they were being conservative about the fact that people could still identify if the race, ethnicity, other groups were small enough that they could identify actual participants of the study. So I think that's my my take on why they grouped it as other. But I understand it's frustrating. I want to see my people, Asian people, are they doing more marijuana? So yeah, I understand. So in the future, if I do it, I want to specify right down. Yeah. Yeah.
So I'm curious about that study too, and your thoughts on cannabis use to self-treat mental health issues. So I guess I'm kind of thinking through the causality in that study, and some of that cannabis use might be to treat some of the characteristics or the characteristics of the product of mental health issues.
Yeah. And we're in Colorado, and I'm just beginning to learn people are doing really wonderful work on edible products that could reduce anxiety, maybe comparing them to just other medication effects, and then see if it's better or not. I personally do not. That's not my focus area, but my understanding from the literature is that the cannabis health effects could use on maybe anxiety, but not anxiety mixed with depression. Because I think one study found out that people who had depression and anxiety, and in the long term, their depression level did not go down. So they were chronically just depressed, but their anxiety level went down. So I think there's no one silver bullet, right? So some would find this super helpful, and some might not find it really helpful. That's my take. Did that answer your question?
Sort of. I guess I'm more asking about maybe users' perception on how on why they're using it and how it's treating their mental health issues, whether it's anxiety or depression. How that would impact that.
Yeah, self-medicating theory is a theory that's discussed in substance use prevention and drug abuse, and I'm not sure how that theory is being supported these days, but substance use definitely is considered in some field maladaptive coping. So they might be dealing with their mental disorders or other stressful life events, and for various reasons they would opt to take substance use as their coping, and then that's almost escape from reality. And I would also say that it's either avoidance or distraction coping styles. So it is possible to look at it that way. And again, another good point, asking about users' perceptions, using a qualitative survey maybe, yeah. IRB approves.
Any other questions for Angela? Great. Well, thank you, everyone, for coming to the talk.
Thank you.